Our next speaker is Dr. Kenneth Calamia. He's chair of the Division of Rheumatology and associate professor of medicine and clinical supervisor in internal medicine at the Mayo Clinic in Jacksonville, Florida. Ken received his bachelor's degree at LSU, his medical degree at Loyola. He was an intern and resident at Mayo and then a fellow at Mayo in rheumatology. He's been listed in Who's Who. He's an advisory board member of the American Behcets Disease Association. He's former vice president of the International Society for Behcet's Disease. He's been a prior associate editor of several journals. He's written the chapters on Behcet's in some of our major textbooks, and he's been awarded the top teacher for rheumatology and internal medicine residency at Mayo. And he's going to give us an update on Behcet's disease in North America.
Thank you, David, for your invitation. You might have included on that first slide the fact that much of my CME in recent years has been at this premier meeting. And I did learn something at this meeting so far, and that Mark Twain was right. It's much more comfortable to be on that side of the podium than this side. But I have had an interest in Behcet's, and I hope to share some things that you'll find useful. Certainly not as common a disease as rheumatoid arthritis, but there's enough of these patients who either have the disease or think they have the disease in our offices that it really helps to have a good understanding about this disease. I have a couple of disclosures, and we will talk about treatment, and of course there's no approved treatments for Behcet's disease. And we'll look at the clinical manifestations of the disease, both around the world in areas where the disease is more common, as well as in the United States, where the disease may vary some from the classic disease. We'll spend some time looking at some of the mimics, especially mucocutaneous mimics of Behcet's disease, which can confuse the diagnosis of Behcet's disease. And for you to have an understanding about some of these mimics will be important. And we'll also talk a bit about treatment of Behcet's disease. So the disease gets its name from a Turkish dermatologist who described patients with mouth and genital ulcers as well as hypopyon uveitis in about 1937. The disease probably goes back to the time of Hippocrates, and if you're Greek, you'll certainly recognize the description of Adamantiades, who described what is probably Behcet's disease in 1931. Since the time of that initial description, however, it's been recognized that Behcet's can have multiple manifestations, and it's thought that these manifestations are primarily due to a multi-system vasculitis, but it's very distinctive, and I think that's the key to recognizing the disease in some patients. This is a vasculitis that affects not only arteries but also veins, and it involves large vessels up to the very smallest vessels. So it's a distinctive vasculopathy, as I think you'll see. The disease has a particular predilection and prevalence along the Silk Road. And the Silk Road is a historic trade route that goes back to before the time of Christ and has been allowed the facilitation of certain intrusions, cultural intrusions, military intrusions, as well as disease intrusions, most notably the Black Death or the plague some years ago. It's thought that the environmental agent or the genetics associated with the susceptibility of Behcet's is passed back and forth along this Silk Road to be responsible for that high prevalence. So it's not too hard to diagnose the disease in patients who have connections to the Silk Road. This was a patient from Minneapolis, which is an area that has taken a lot of Somali refugees, and she had mouth ulcers, but she had this also very distinctive vasculopathy with pulmonary artery and systemic artery aneurysms and clots in the right ventricle and the superior vena cava. So Somalia is sort of a side road off the Silk Road, not too far, but you can imagine that travel by water is pretty easy to get to Somalia. And if you look at the prevalence of Behcets along the Silk Road, it's very highest in Turkey, where the prevalence is 370,000 per 100, or 370 per 100,000 patients, and it is similarly high along the Silk Road, as opposed to Europe, where you can see it's quite a bit lower, the highest in Southern Europe, in the range of 7.5 cases per 100,000. So I have to make a confession that my interest in Behcets is not because I wanted to stamp out every aphthous ulcer in the world. I knew having an interest in Behcet would require a certain amount of necessary travel to centers that had some experience so I could become knowledgeable about the disease. So first I got an invitation to the Behcet Center in Istanbul, where he practiced. As I mentioned, he was a dermatologist, and got to see how they followed their large group of about 5,000 patients. That's all they do on Mondays is see Behcets, and learned how to do pathology testing, saw some of the manifestations of the disease there. And this was quite a multi-specialty approach to the treatment of these patients. The difficult patients at the end of the day were presented to the multi-specialty team, rheumatologists, ophthalmologists, dermatologists, who would share the history and what the problems were and come to some kind of consensus about the treatment of whatever the difficulty was. The manager of the Behcet clinic had Behcets himself, being there so often over the years. This is Hasan Yazıcı. He's the chairman of the division of rheumatology in Istanbul. His son is in New York, and he's probably the world's foremost Behcetologist. And we made rounds in the hospital in the classic European style. From there, I went to Tehran. This was back around 1999, and was privileged to be able to participate in the clinics there in Tehran. Under the direction of Dr. Davachi, patients are seen at 3 or 4 data collection stations before they even get to see the physician. Every ulcer they have, every skin spot, everything's cataloged and has been for about 30 years. So their 5,000 or 6,000 patients is a tremendous source of information about the disease. More disease manifestations from blood clots, very common, varices from vena cava, occlusions, and this too a very multi-specialty group. So you have to add on a little time in other parts of Iran, which was a very nice trip, and get to enjoy some of the local products as well. Let's talk about another patient. This is a 29-year-old fellow who had mouth ulcers and also a distinctive vasculopathy. Started off with superficial thrombophlebitis, gets a cardiomyopathy, he's got an abdominal aortic aneurysm, he's got renal artery aneurysms, he's 29 years old. This is his CT showing his abdominal aneurysm, but he's Boscobelian. And Boscobel is a little town in Wisconsin, not too far from the Mississippi River. And this disease does occur in the United States. It's a rare disease, but you certainly have to be recognized when the disease does come along. And we did a study, a population-based study around the Mayo Clinic in Rochester, Minnesota, in the county, Olmsted County, and the prevalence of the disease in Olmsted County was pretty high at 5.2 per 100,000, clearly as high as it was in northern Europe and as high as it was in the southern part of Europe. So Rochester, Minnesota's population is a little unique because of the Mayo Clinic and people coming in and out from all parts of the world that choose to live there, but clearly the disease does come. There are differences. Along the Silk Road, men historically have been affected with the disease more frequently than ladies. The disease tends to be more severe. Part of that severity may have to do with the fact that Women are more commonly involved in Europe and in the Americas. Central nervous system disease is infrequent along the Silk Road in most places, more common in Europe and the United States.